Hello, everybody, and welcome to this webinar. My name is Dr. Dan Lowe. I'm the Chief Medical Officer at Adaptix. I'm also a pediatric anesthesiologist and faculty at University of Washington and practice at Seattle Children's. Today, we're going to be talking about a topic that is very near and dear to our hearts on this call. We're going to be talking about advancing health equity and looking specifically at the intersection of technology, AI, collaboration, real-world data. I'm joined by an amazing panel with really rich experience. We have Dr. Angela Shippey. She's a senior physician executive from Amazon Web Services. Prior to her current role, she was the Chief Medical Officer and Chief Quality Officer at Memorial Hermann Healthcare System, and previous to that, CMO of St. Luke's in Texas. So brings a huge amount of operational and clinical leadership to her current role, and she's helping healthcare systems with their cloud adoption strategy and and digitizations. Thank you for joining us, Dr. Shippey. We'll also have Dr. Tina Cordero. She's a Senior Project Director with the Joint Commission, and her team is responsible for developing and healthcare standards for their various accreditation programs. And she's one of their subject matter experts for health equity, telehealth, and antibiotic stewardship, and delighted that you can join the call today. And then we also have Dr. Jen Chim. She is the Director of Anesthesiology at the Bellevue Clinic and Surgery Center at Seattle Children's, and also one of my colleagues. And I've had the honor and privilege of working alongside Dr. Chim for quite a few years. She did her anesthesia residency in Rochester and her pediatric fellowship training in Seattle. And now she's my boss on my other day job. So delighted that you can join the call. So let's start with a little bit of history. So I'm going to date myself now. Do you guys remember when the Institute of Medicine published their report about, I don't know, 20 years ago, when we first understood that disparities really exist in healthcare? That was about, I don't know, 20 years ago. And I want to trace that arc of history from that report to where we are today. And maybe I remember reading it. It's just not long after I graduated med school. And I was thinking, wow, at least we've actually quantified it. At least we recognize that disparities exist across racial lines, across language lines, and that it's systemic. And at least we can now address it. So let's trace that arc of history and see where we've come from. Angela, could I start with you? Could you share with us a little bit about your current role and how AWS and specifically digitization of healthcare data is helping that journey?
Hi, Dan. Thank you so much. And I'm so excited to be here with this panel and really talk about health equity. I would say I agree with you. I mean, when we think about our careers in medicine and how we were trained, so many times when we would see patients, a big part of helping them get better was about looking at their community resources, looking at socially what was happening with them to improve their care. And in my role currently in the global healthcare and nonprofit team, I have the opportunity to talk to hundreds of healthcare customers throughout the year. And one of their key pain points is talking about how do they take better care of patients in their community. So many times healthcare providers are the largest employer in the community, so they have that population that they employ that they're taking care of, as well as communities that are underserved, that may have particular obstacles to good health. And so they're constantly looking at how do they do that better. And what they've seen is when they have data that allows them to understand the community, who lives there? Are they multi-generational families? Where do they work? What kind of access do they have? When they're able to bring all that information together, it allows them to have some really good insights that are actionable. And what's so incredibly important about that, as I'm listening to those conversations is the fact that they want all the data to allow them to do that. So they're looking at community health assessments, they're looking at information from their electronic health record, other nonprofit organizations in the community that they're working with. How do they bring all of that together, make sure that it's there in real time at the time of service when providers and others in the system are working with a particular patient, and then really be able to utilize that? So one of the things that we did over the last several years at AWS is we really made a commitment to health equity. We understand that, again, the social determinants sometimes are the biggest barrier, as well as access to care. So we partnered with many of our customers to say, how can we help you in advancing health equity? So through those collaborations with over 377 healthcare providers globally, we were able to provide access to credits and funds that allowed them to improve the access to health services, that allowed them to work in better collaboration with those nonprofit organizations within their community that were helping patients. And we were also able to see what was the impact of climate change, quite honestly, on the health of those communities. And so ultimately, what does this all really mean? It means that now we are in an environment where so many health systems are able to say, I know where my patients are. I know exactly what they need. I'm able to provide them access to care and services. And with that, I'm helping to overall improve the health of the community. And so I'm really excited that we're all here today talking about this. We're talking about what is that arc from over 20 years ago and how we've gotten better at being able to say, yes, we know that health equity is important. We have the data that tells us that, and we have the data that's allowing us to make the right decisions and to have the right interventions at the right time for those patients.
And thank you. And it sounds like it's not lack of data that's the problem. We are collecting so much data, but as you say, it's the challenge now is being able to synthesize it and put it in a form that is usable. So we can do that. And
Yes.
I just want to thank AWS and your leadership for the commitment. And we've seen that time and time again now, especially kind of like helping healthcare systems and helping providers kind of do that. So thank you very much, AWS.
Yeah, well, thanks, Dan. What I appreciate more than anything is that opportunity to collaborate with our customers and, to your point, bring all of that siloed data together to have the actionable insights.
Right. Well, thank you, Angela. Tina, I'd like to kind of ask you a little bit about your work at the Joint Commission and how you see the impact of some of the regulatory work that you've been helping them do into this space.
Sure, Dan, and thanks for the opportunity to talk a little bit about what we've been doing at the Joint Commission to advance healthcare equity at our sort of individual organizations that we work with, both on the accreditation side and then with our new healthcare equity certification program. And so a lot of what we do at the Joint Commission is really try to embed concepts of healthcare equity into our requirements. And then when our surveyors go on site at these individual organizations as part of their larger accreditation survey, we can take a look at the type of data that they're collecting around healthcare equity and look at the potential disparities that they've identified, ask questions about how they've done their analysis, which quality and safety measures they're using, and how they're stratifying their data by the sociodemographic characteristics of their patient population. And so it gives us kind of a different angle to have these kinds of conversations at the individual organizations. And then on the accreditation side, we have a national patient safety goal that focuses on healthcare equity that really allows our surveyors to have those conversations with leadership at these organizations across the country. And like I said, hear a little bit more about how they've prioritized healthcare equity, what type of data that they're looking at, what they've learned from that information, and then what those action plans are that they've put in place to close those gaps.
Amazing. For our listeners, they might not be aware of how recent this work is. So could you tell us a little bit like, has it always been that way? When you check into a doctor's appointment, that you have to fill out a form that actually asks you your race and preferred language, or, how recent is this?
We've had healthcare equity. We've been in the healthcare equity space for a long time. I have this sort of long timeline slide that I typically show that says, maybe around the same time as that Institute of Medicine report, we've always had projects that have looked at equity and trying to figure out if there's a way that we can encourage our accredited organizations to involve themselves in that data collection and that analysis. But I would say in the last couple of years, we've have embedded healthcare equity into our larger health agenda, which really focuses on our strategic priority that really include health equity, environmental sustainability, looking at the role and responsible use of data, and just performance improvement. And so healthcare equities was always part of the work that we've been doing over the years, but really took kind of a more strategic role in the last several years. And I would say in July of 2023, we released that national patient safety goal that I mentioned in all of our accredited hospitals, many of our ambulatory program organizations, and some of the behavioral healthcare organizations as well, just to start to have that kind of conversation with leadership around equity. And then in July of last year, we also launched that new certification program, which is kind of a freestanding program that looks at hospitals in particular that are really excelling in this area and focused and committed to healthcare equity, and kind of gives a specific healthcare equity review of the policies and the processes that they have in place.
Wow. Well, thank you for the overview. And maybe I'll just come back to one more question. Is like, so from your point of view, how far along are healthcare systems on solving this problem? So a problem that we've now known for 20 years. How close are we? How much more work do we have to do? Are we nearly there? Are we just starting? How do you feel about this?
I think it depends. I mean, we know healthcare equity is a journey. So some organizations have been doing this for a long time and have been routinely asking all of their patients about race and ethnicity and preferred language, asking about health-related social needs at every interaction, looking for changes. And then they sort of have that data that they've been collecting. And those are the types of organizations we're seeing in our certification program. And so we know organizations are doing that, and some of the systems have been doing this for a while. But then we've also seen organizations that are just starting out in this work and really looking at some of the resources that we've put together on our website to help with implementation, because we know, sometimes we've had requirements around race, ethnicity, and preferred language data collection, but the health related social needs and some of the additional details that we're asking for now, some organizations that are starting out to ask these questions for the first time are looking for resources and help with how to sensitively obtain that information, how to ask when to ask those questions, and then how to collect data, as you mentioned earlier, in a meaningful way that they can then use for analysis to learn a little bit more about their patient population and potential disparities.
That is wonderful. And thank you for that summary and overview.
And I was just going to add, Dan, as I was listening to Tina talk about this, when I think about being in my former role, whenever there's a national patient safety goal, it's an opportunity to really rally around an important area of emphasis within healthcare. And then there are resources that come with that really help an organization move forward. And I will tell you, in my experience, it wasn't that the information wasn't there, it was that it was in many places. So where was going to be the one source of truth where it was collected in the electronic health record where everyone knew to go and get it? And then how could you utilize it? So that's one of the reasons why it's so incredibly important to have everybody who's on this panel talking about this and bringing it to the forefront. And when you have a national patient safety goal and those resources to help you move forward in a very important initiative like this. So really being able to say, this is important, an organization rallying around, how are we going to do it? What is their journey going to be? And then having like partners and collaborators like AWS who come in with the Health Equity Initiative and are really putting resources to help people have that data in one place.
That's a perfect segue. I'm going to turn. I want to kind of hear from Jen in just 1 second, but just to give our listeners and our watchers, the people who've dialed in, an idea of what's possible today, and then we'll hear from Jen about how she's actually impacting care on the front lines today. So I'm just going to switch over to, so we are collecting the data, we are we are housing it in cloud solutions. We have healthcare systems are collecting demographic, race, and ethnicity data. And now what can you do with it? And this is one of the topics was the intersection of AI, which is all only possible because of cloud computing. So this is a hospital, a women's and children's hospital that was one of our joint customers, Angela, down south, and we actually have. Let me just hit Equity AI. It literally takes a microsecond. It's actually run through their entire population in literally less than a second. That was live. And it's looked at all the processes of care. So times to, C-section, decision to incision, how long you stay afterwards, even the number of opioid pills on discharge. It's got metrics like blood transfusion rates, recovery, newborn outcomes. So then here you see, look, it's got the number 9. It says, I've surfaced some things for you. And it says you may have a disparity in how you administer blood transfusions based on ethnicity, language, and race. And if you just click on the button, it says, yeah, if you happen to be Nicaraguan or Guatemala or unknown, you have a 40, 90, or 180% chance of having a blood transfusion. If you look at language, it says, if you speak American Sign Language or Arabic, you have a 200 or much higher chance of needing a blood transfusion. And if you look at it through the lens of race, and it says if you are Asian or mixed race or Black, you have a 36, 58, 60% higher chance of a blood transfusion. So this is the kind of insights we now can deliver that used to be buried in a chart. So this is obviously not Seattle Children's, this is a women's hospital, but Dr. Chin, Jen, tell us, you've had access to Adaptix, you've had access to digitized data in your role as a director of anesthesiology at the Bellevue Surgery Center. Can you tell us a little bit about how you've been able to use this?
Yes, absolutely. Thank you so much for having me. So one of the earlier projects that I used to delve into before I even entered this role was just seeing what our clinicians were doing in terms of adhering to the protocols that we do have at our surgical center. So, for example, we do a lot of tonsillectomies, we do a lot of adenotonsillectomies, and one of the core measures is giving post-op nausea vomiting medications, typically 2 of them, especially in the pediatric population. And so asking the question, how often are we actually adhering to this protocol? And comparing what we do in a protocolized standard at the ambulatory center, 98% of our patients were getting 2 medications for post-op nausea vomiting. The ones that weren't getting the 2 types of medications were for medical reasons, that they had a particular diagnosis that excluded them from receiving these 2 medications. They at least got 1. Mm-hmm. Comparing this data to our main hospital campus, where there's not necessarily standardized protocols for tonsillectomies, we noticed a potential disparity there, that only 77% of patients were getting dual prophylaxis. And then that subset, when looking into that data, it was primarily our Black patients that were not getting dual prophylaxis. And so bringing this disparity to our staff meetings, to our otolaryngology lead for the anesthesia side, and trying to delve into why is this happening and why, or how can we make this better? And so bringing this at a staff meeting, having the discussions with our team, re-emphasizing to our trainees that this is what we're supposed to be doing. Within a month, we saw that 77% adherence to dual prophylaxis jump up to nearly 95%. So it was comparable to what we were doing down our ambulatory surgical center. So that's just one example of just asking the questions and utilizing this new technology to help us make clinical decisions in the workspace and actually benefiting our patients in the post-op care time period, because the patients that weren't getting 2 types of anti-nausea medicines were obviously having nausea and throwing up in the recovery space. So that delays their time in order to go home. It requires extra medications in the recovery space, and a much less pleasant experience recovering from surgery overall.
So you were able, as a leader, to take this data, which is pretty complex and vast and coming at you fast, be able to get an insight, just as Angela was saying, and identify a disparity, take it to the group, and then put an intervention. The intervention here was education, right? And accountability. And you were able to see if that was effective almost immediately. And not only are they doing it, but what's the effect on the patient outcome, right? So it's come full circle. You can do the whole thing. That's an incredible story, and just a great use case of tying this conversation together. For everything from, if we didn't collect the data, we wouldn't be able to do it. If we didn't have the technology, we couldn't do it. If we hadn't digitized, we couldn't do it. If we weren't in the cloud, we wouldn't be able to do that. So thank you for sharing that. You recently authored a paper on learning health systems, which is I'd kind of like just to dive into that a little bit. What is a learning health system, and how does that apply to well, tell us what's changed. What made you write that paper?
So over the past 10 plus years that our ambulatory surgical center has been in practice, we've made iterative changes to all of our different protocols across all surgical subspecialties. And so taking together this big overall arching plan of looking into how we're changing on a day-to-day basis, and in the long term, how does this change and benefit our patient populations in terms of environment, in terms of equity, in terms of effectiveness, looking into how do we get more access to patient care by looking at how effective we are in time from anesthesia start to time to when surgery starts, from when the surgeon walks into the room versus when the surgery stops, taking into that consideration and standardizing the protocols and steps that each of our team members play to minimize that downtime, allows more patient throughput. Another example is in terms of our environmental climate change practices, education, taking away nitrous oxide from our anesthetic use has decreased our amount of greenhouse gas emissions from our hospital overall, and seeing that drastic change as everyone learns from each other and is in a competitive nature and trying to outsource the other person in terms of being the least amount of greenhouse gas emissions for our team. Has seen a great improvement in that. And then in terms of when we are looking at discharge criteria for our tonsillectomy patients, how often are they coming back in that 30-day time period with a potential tonsil bleed? We were noticing that patients who were Asian and Hispanic tend to come back at a slightly higher rate than our white patients. And why is that? We delved into kind of bare basics in terms of what does our discharge paperwork look like? Can we have a visual for how many cups should patients have after discharge rather than writing it out in letter form? And educating the nurses, educating the otolaryngology nurses that are receiving those calls from patients at home, and reiterating that message for helping patients and families troubleshoot at home. And we saw this decrease over time after we implemented this new discharge paperwork strategy of patients not coming back into the hospital during that 7-day period for tonsil bleeds.
Wow, so that's another example of, again, tying together our previous conversation to a very practical, I can figure out who's coming back, who's bleeding more, and that's a serious complication from a surgery, and even look at it through a DEI lens and actually figure out how to improve that. Amazing. So that paper was in mid 2024. We're at the end of 2024. So does that mean we're done and we declare victory, and or is there more ongoing work that you can share with us?
Oh, there's definitely always room to improve, but it's a never-ending cycle of where we can always do better. And so taking into that consideration, one of our fabulous PACU nurses looked into creating an educational video for patients and families to watch while their child was having surgery to anticipate these potential complications of going home, what to look out for, how much hydration. So it standardizes the script and the instructions that every patient was getting. We translated this video into Spanish as well for our Spanish-speaking population. And we saw a decrease in the PACU length of stay because parents were already seeing this video while their child was getting surgery. They had the access to this link at home if they had questions and concerns and wanted a refresher. And we saw that length of stay decrease by 10 minutes. And it's been almost a month now, but we are seeing a decrease in trends of 30-day return to the OR, 7-day return to the emergency room for concerns after tonsillectomies as well. So it's an amazing feat and amazing effort by all of our team members to think of creative ways to do better for our patients.
That's amazing. And we were reviewing the data earlier on. For Spanish families, the decreased length of stay is 19%, which is a big deal. And for English-speaking patients, it's about 13%. So, and this reminds me of a very famous. Famous quote. I'm going to say it's a famous quote. I heard Kedar Mate speak at his keynote. He's the CEO president of the AHI. And when he was introducing equity at his keynote a few years ago, he said, you can't have quality without equity. And one of the things that is now, I've seen time and time again with your work and the team's work at Bellevue and at the Seattle Children's, is every time you address an equity issue for one group who's disadvantaged or there's a disparity identified, once you fix it for them, you fix it for everybody. Everybody benefits. And we've seen that time and time again now. Well, I think we're coming up to time. And I just, and that we really have come full circle. We started, Angela, you started with the whole digitization journey and, movement to systems running towards cloud computing and cloud solutions. And Tina, you shared with us how, the Joint Commission and other regulatory bodies as well have been kind of encouraging more and more strongly over the years to please keep these, get this data. And with the belief that leaders like Jen would be able to now really affect how, see these disparities and see these inequities and put plans into action and then know if they're working or not and actually improve the care for all our patients. So I'd like to thank everybody for coming today. It's been a great conversation and a great summary of 20 years. And I'm actually leaving this call more hopeful about our future. I think we're in a place where we are positioned from a cultural point of view, from a technology point of view, from a data collection point of view. All these things are lining up so we can do some more of this work at scale. So thank you very much, everybody, and all our people that tuned in. Thank you for coming in.
Thanks, Dan. Thanks, everyone.
Yep. Thanks, everybody.
Thank you.
Hello, everybody. Thank you for tuning in today to our webinar. I'm happy to take some questions. I can see a few on the chat already. We had a question from Laura asking about SOGI data. So that's a great question. Yes, we are now seeing healthcare systems collect data now for sexual orientation and gender identity. It's not uniform, and it's a little bit behind the data rates for collection of race, ethnicity, and language. But definitely seen in the last couple of years a trend moving that way. Obviously, it's more sensitive information, and so the adoption and scale of that might be slower. But definitely it's moving that way. The key thing is that we're now able to take data about the processes of care, like Dr. Chim just said. Are you getting this treatment versus not getting it? And we're able to stratify the process of care by these through a DEI lens of who's getting it, who's not getting it. We're also able to look at the outcomes of care, and adding the SOGI data as another way of stratifying would be a major step forward. So certainly encourage healthcare systems to do that if you're not already doing that. We had another question come up in the chat asking about data, and that's as a data nerd, happy to see that question come up. The question was, you're looking at raw percentages. How do you know a disparity is a disparity? So we took Adaptix took the playbook from the IHI. So they're the leading organization for improving healthcare systems, and we took their methodologies for data and data analysis, and a lot of it is plumbed into or derived from statistical process control charts, because we're looking at real world data. We're not doing is we're not conducting a trial and saying, hey, moving forward from today, do certain groups of patients get better care than other groups of patients? And so we're not doing that. We're taking our system as it is and running a diagnostic on it today. Hey, so what Dr. Chim's example was, they noticed at Seattle Children's that Black patients having a tonsillectomy have 3 times the nausea and vomiting rate as everybody else. That was the observation. When you delve into it, you realize that the dual prophylaxis was not being applied equally across racial groups. And that was unknown to us. And so being able to look at the data, surface that, and then put an intervention saying there's no good clinical reason that should be the case, overnight, literally overnight, it almost, it was above 95% compliance with dual prophylaxis. And the outcome got 3 times better for our Black patients overnight and stayed that way. So yes, we're looking at raw percentages. Yes, we're looking at outcome data. Yes, we're looking at process data. And when we see a gap that's unexplained, we put interventions in to close that gap and use the data to assess, are those interventions successful or not successful? If they are successful, keep doing it. If they're not successful or not wholly successful, go back to the drawing board, come up with another idea. And so that is how you become a learning health system. You take your processes as they are today, and you ask yourself, how can I make it better this week, this month? And then you apply those ideas and implement those ideas, and you see if your system improves. What other questions do we have coming up in the chat? Okay, I see another one. We had if a hospital wants to improve equity, where's a good place to start? Well, you've heard from our Joint Commission colleagues today, and you've also heard from our AWS colleagues. And I think I've just underlined that. If you are not already robustly collecting the data for to do DEI work, so the minimum bar is race, ethnicity, and preferred language. Get the SOGI data, that's even better. You are already collecting reams and reams of real world data. And that term, I mean, so if in the modern healthcare system today, we all have electronic health records. There's a digital trail or digital breadcrumbs, if you like, of your patient journey, whether you come through the emergency department, whether you come through the ED or the urgent care, or you come in for a surgery through the operating room. There's a literally digital breadcrumbs scattered representing your patient journey. You already have that. Every healthcare system has that. Because you have that, you are able to look at the individual processes of care, delivery, in the ED. How long does it take to come through triage? How long does it take to get a CT scanner if you have a stroke? How long does it take to get antibiotics if you have sepsis? You have those processes mapped out. You can, if you have the DEI data, which many of you do, you can now say, well, is my time to get a CT scan if I have a stroke 15 minutes, 20 minutes, 25 minutes? What is it? Show me my system. Stratify that data. Does it make a difference if I'm Asian? Does it make a difference if I'm Black? Does it make a difference if I'm white? Does it make a difference if I speak Spanish? Patterns will start to emerge. You might not, it might be upsetting or unpleasant or morally distressing to see it. And that's a common theme when we start this journey in this work. It's sometimes hard to look at in the mirror, but it's better than not looking at it. And once you look at it, you have to respond to it. And the way you respond to it It's just with kindness and empathy and compassion for the team who actually do the work. What we've seen really, really successful at our hospitals who really made big strides is they share the data with the team in a non-punitive, non-blame way. So these are our results. And you let them sit with it for a little bit. And then you ask them, what ideas do you have? Especially the clinical teams, you're closest to the work. What ideas do you have to close these gaps? Your job as the leaders then is now to implement their ideas. Put them in. If there's barriers to implementation, it's your job as leaders to knock down those barriers, implement them. Then use the data again. Once you've implemented it, did it work? Did you close the gaps? Did you improve care? Did you reduce those inequities? And then just rinse and repeat. Thank you for that question. Another, more data questions. Another question that just came through is we had a question about how good does your data have to be to start this work? Okay, I'm going to go back to my previous point. We're dealing with real world data, so hospital systems are collecting data. Just because we have moved from paper to electronic health records, we are collecting data. Is it perfect? No. Will it ever be perfect? No. So my counsel and advice is it's already good enough. It's never going to be perfect. If you wait for the data to be perfect before you start, that's a good excuse not to start. So you can don't let perfection be the enemy of it's already good enough. So you can start this work with the data you have. Is it going to be missing sometimes? Sure. Are some people too embarrassed to ask what your ethnicity is or what your preferred language is? Yes. But that's an ongoing education process for your staff. You already have sufficient data. Most of your the systems that are on the call today, you already have enough to embark on this work. If you wait for everything to be perfect and everything to be collected perfectly, we'll still be having this conversation in a decade or two from now. Thank you for that question. We've got some more questions. How could this tool be used within primary care? Great question. So Adaptix think of it as a self-service clinical management solution. It can be that leverages your real-world data, whether it be in primary care, urgent care, ED, inpatient, the operating room. It doesn't really matter. I think of primary care and clinic-based medicine. It's not unlike an OR. You just don't cut people, right? So if you're making an appointment to primary care, let's think about that journey. There's access. How long is it from requesting an appointment to getting an appointment? Let's just take that. We've worked with clinics-based systems who looked at that and go, wow, does it matter? Okay, it might be 6 days to get an appointment. Does it matter if you speak English as your first language, Spanish, Cantonese, French? It doesn't, right? And we've seen systems where there's patterns that emerge that if you speak Asian languages, you have to wait longer for an appointment. And then when we dived into that, it was super interesting why that was. And the schedulers were told if a patient family requesting appointment calls for the 3rd time, they were told to give them the next available spot. And now you've butted up against a cultural issue. If you are empowered and able to self-advocate and call to request an appointment, and you keep on calling, you get to the top of the line. Certain cultures, mine included, my parents, immigrants from China and Hong Kong, they would never have called a hospital system to demand or request an appointment sooner. They would have culturally considered that rude, and they're very busy people and you shouldn't disturb them. So they would never call. As a consequence of that policy, you get an appointment a lot later. So, okay, now pretend you're inside the primary care clinic. What else can you use it for? Well, you have lots of quality indices in primary care. Did you ask about fall assessments? Did you ask for suicidal risk? Did you ask for mental health? Did you do, there's a range of fairly low-hanging fruit if you ask those questions or you do those surveys, you get quality points awarded to your system for that. Well, you can look across racial lines, language lines, ethnicity lines, social lines if you have that data set. Who's getting that service? Are you applying that appropriately? So yes, that was a very long answer to a very short question. Can this be used in primary care or clinic-based settings? The answer is yes. We have some more questions. We have a few more minutes. How can you track cost savings, if any, or ROI? Well, that's a great question. So anytime you're asking a health system to adopt new technology, whether it be Adaptix, whether it be cloud computing, this person writing or the committee writing the check wants to see an ROI. I'm going to go back to what Kedar Mate said, the president and CEO of the IHI. He said, if you can't have quality unless you have equity. You can't achieve quality unless you have equity. Okay, so if you achieve quality, that is your ROI. So I'm an anesthesiologist. Let's take something easy. Let's take a hip replacement. Okay, that's probably one of the most common surgeries done in the USA. If I told you that the quality index I want, and you all measure this, is 30-day return to OR for wound dehiscence or wound infection or cement failure or something like that, that is a quality index. Now you might be tracking 1%, 2%, 3%. If I told you you had a racial group that was tracking at 5 or 6%, and you went after that and you improved it for everybody, and now your system is tracking at 0.5%, that is quality. That's also, it reduces your cost, it reduces your spend, it also earns your next patient. If you have a reputation of having the lowest surgical site infection rate after a hip replacement, of course that drives revenue. So I think there's a double win there. If you use equity to drive quality and quality to drive revenue, there's an ROI which isn't like a far-fetched make-up fairy tale story. It's very, very real. Next question. Are there some sample AI tools we could implement in our hospital? Yes. What are some sample AI tools we can implement in our hospital? Yes. I only got a chance to show you very briefly the demonstration of what was possible. In the 3-second clip, it was a 30-second clip, but the 3 seconds it took, Adaptix is a solution that has a bunch of AI tools embedded. So you hit a button and say, find me all the equity issues that might be existing in my hospital. And it looks across every service line, every hospital in your system, every process of care and every outcome. And then it categorizes it and it rates it and it serves it up to you. So that is something you can implement today. Anyone who wants a further discussion on that, please hit me up. I'm easy to find. Adaptix.com is our website. We're happy to have an offline conversation about that. So these tools are available today. Every hospital can implement them. It's not just for equity work. It can be used to do quality work. It can be used to drive efficiency. I think of it as the 3 E's. Like you can use it to drive operational efficiency, clinical effectiveness, and also with an equity wrapper around it, if that's work that you want to pursue. Thank you for that question. We have another question. Where can we find funding for these important health equity improvement practices, as the involved institutions are less likely to fund them? Okay, so funding. So how are you going to get funding to drive this enabling technologies? I would start at the top. Most hospitals have as a strategic pillar, at least publicly facing, if you go to any hospital's website, now most of them have equity as a strategic goal. Anytime you can align your work with a hospital's stated strategic goal, your chance of getting funded by the hospital goes up exponentially. So my advice is, if you're I'm not sure who that question came from. If there's if you're a group within a hospital and you want to pursue this work and you think, oh, I've seen enabling technology, I would go right to the top. I would go right to your C-suite and say, hey, I have a proposal. There are enabling technologies that allow us to do this work that you want us to do. The C-suite aren't going to do this work. It's the people closest to the patient care who will do this work. It's the frontline staff. It's the chiefs. It's the division leaders. It's the folks in the trenches who are going to do this work. We're asking you, C-suite, please, to give us the necessary tools to surface these disparities, so that we can identify the gaps, so that we can solicit ideas from our staff, so we can implement those ideas and then use the technologies and the data to understand if it's successful. And if it's successful, we'll move on and do something else. So that's the conversation to have. Again, I'm happy to engage with any of you on the call with that. Again, contact us on adaptix.com or just find me. It's easy to find. I have time for one last question. Is this tool integrated with the EHR to auto-pull patient characteristics? It is almost yes, is the answer. The tool is, so the EMR, if you think about the EMR is no more, no less than a system of record. I'm a frontline clinician, have been for over 20 years. My job is to document care in the EMR, just as my job 20 years ago was to write it down with a pen on a paper chart, is to document the care. So the EHR has become the system of record. What Adaptix is, what AWS enables, is a layer of intelligence to sit above that. If you open your EMR, whether it be Epic or Cerner Oracle Health or Meditech, right now, you are able to open one patient's chart at a time to do a deep dive on one patient. That is what it was designed to do. It was not designed to let you ask questions across your patients to assess workflows, treatments, protocols across your patients in your hospital to determine what's working, what's not working, is it getting better, is it getting worse? That is not in their sweet spot, it's not in their wheelhouse. So Adaptix is takes advantage of the fact you have this robust digital system of record, and we're an intelligent system that sits on top of that data. So I think that's the best answer to that question I can give today. Again, if you want more information, happy to engage. Our website is adaptix.com, and you can just hit us up on the contact us channel there, and we'll be happy to talk to you more about that. We're down to our last minute, folks. I just want to take the opportunity to thank everybody for their time. Thank you all for your engagement. Thank you for your excellent questions. And I can still see questions coming through the chat. You know how to get hold of us. I'll be delighted to follow up with all of you. Thank you for engagement. Thank you for your enthusiasm for this work. And I believe if we all work together, we can deliver more equitable care and improve our healthcare systems together. So thank you very much for tuning in. I'm grateful for your time today. Thank you.